Hi everyone, thanks for listening to my presentations today. I'll be talking about Thyroid Storm. The presentation will be on Thyroid Storm, and this will form part 6 or 7 when it comes to hyperthyroidism. If you haven't listened to parts 1, 2, 3, 4, and 5, please kindly do. With that, sit back and let's go. Thyroid Storm. This is a life-threatening medical condition. Life-threatening. This will have exaggerated symptoms of thyrotoxicosis. You can check my channel for a complete note on thyrotoxicosis. However, one good thing here is that thyroid storm is rare. What are the risk factors that would treat anyone into thyroid storm? Long-standing hyperthyroidism or untreated hyperthyroidism or inadequate treatment can treat anyone to thyroid storm. Graves' disease, not adequately treated. Toxic multinodular goiter, not attended to. Solitary toxic adenoma, thyroid surgery or non-thyroidal surgery, tremor, infection. Still on risk factors, acute iodine load, parturition, sudden stoppage of anti-thyroid medications, increased T4 and T3, and of course decreased thyroid stimulating hormone. Possible clinical symptoms and signs will include severe nausea, severe vomiting, and diarrhea. There could be tachycardia, hypotension, arrhythmia that may or not involve atrial fibrillation. And of course, all these could lead to congestive cardiac failure. Still part of the symptoms is hyperparesia, agitation, anxiety, delirium, and psychosis. Still on signs and symptoms of thyroid storm, it's very possible to have abdominal pain. Liver could be failing and be dealing with hepatic failure, jaundice, altered level of consciousness, stupor, coma, and if no immediate intervention, death. On physical examination, we might likely see goiter or Graves' disease of thermopathy. Physical lead lag and retraction and everything that realm. Hand tremor, thermopathy, warm and moist skin. We don't have the luxury of time here. It's an acute, life-threatening emergency. So the diagnosis will quickly be made, and it will involve everything I've said before now. The clinical features, the probable diagnosis, a complete history, physical examination, and then we'll head to lab. Thyrotropin receptor antibodies level should be acid. The iodine uptake determined. Ultrasound of the neck region, particularly the anterior neck. Thyroid function test done, and we should have feature of decreased TSH, increased T4 with or without increased T3. When glucometer is brought and we assay, the glucose level is likely going to be raised. Calcium will be high. White blood cell may be high and may be low. Increased metabolism of medication will likely occur in the face of hyperthyroidism because hyperthyroidism increases metabolism. Okay, so we have to take this into account and give a slightly higher doses of medications that we'll be using. But we have to be careful and be watching out for the side effects of the medications. Treatment. Yes, this is where we're going because this is an acute life-threatening condition. If no treatment on time, death can ensue. Admit into intensive care unit. Check the airway. Any foreign body, any secretion, anything to be suctioned, please go ahead quickly. Breathing. B. What is the respiratory rate? What is the O2 sat? Chest moving with abdomen. Any deformity in the chest region. Deviation of the trachea. Percussion notes. Auscultation. Adventitious sounds. Everything. Now, central cyanosis of peripheral. Check that. Circulatory system. What is the vital signs there? No? What is the BP? The heart rate. Is cardiac monitor hooked up? Are we having any arrhythmia? No, on the EKG? Everything done quickly. 2 IV lines. IV fluid gets ready. You can give IV fluid, but you may need diuretics, particularly in the face of congestive cardiac failure. Remember, I mentioned that as part of the possibility or presentations, right? So grab diuretics if you are dealing with congestive cardiac failure or pulmonary edema from the IV fluid that we administer. We have to treat any identified etiology, particularly infection, because that could be easily handled, right? Foley's catheter, fluid in and out. Want to know whether retention is occurring or not, or else we'll be dealing with another serious problem, or edema everywhere, including the brain. Okay, radioactive iodination. Iodinated radiocontrast to prevent the conversion of T4 to T3. Still on treatment. Iodine solution is welcome here. And why that? To block further hormone synthesis. You can keep Lugol solution till 1 hour after the administration of Propylthiouracil. Beta blocker, for example, Propranolol, could be used for tremor, tachycardia, or atrial fibrillation. Metoprolol could be used by oral in heart failure. Digoxin could be used for heart failure with arrhythmia. So Digoxin is welcome here, particularly if we have heart failure at the same time with atrial fibrillation. Thionamide. For example, Propylthiouracil, Methimazole, or Carbimazole. We can use these for inhibition of new hormone synthesis. Propylthiouracil is better when we are thinking about decreasing T4 to T3 conversion. But Propylthiouracil is less used compared to Methimazole, probably because of the side effects of Propylthiouracil that is worse compared to Methimazole. But Propylthiouracil is the drug of choice if you are dealing with thyroid storm in a pregnant woman or lactating mother. Propylthiouracil and Methimazole can be given suppository or Propylthiouracil by retention enema. glucocorticoids. They are very useful here because of the possibility of decreasing the conversion of T4 to T3. In other words, less T3 will be formed from T4 and also can promote vasomotor stability. They have the capability of decreasing autoimmune processes found in Graves' disease. But we have to watch out for adrenal insufficiency because glucocorticoids could alter the normal transmission, sending a negative feedback to hypothalamic pituitary adrenal axis. Okay? And why using glucocorticoids will tail off when we're about to stop using it. But if along the line we've done everything and we still find adrenal insufficiency, we must treat appropriately. Bile acid sequestration. Someone is asking me, what's your business with bile acid sequestration in Thyroid Storm? Yes, I do. To prevent enterohepatic circulation of thyroid hormone. Example is cholestyramine. Plasmapheresis is welcome here to remove cytokines, antibodies, and thyroid hormones from the plasma. Remember, this is a life-threatening condition, so we want to do everything quickly within the shortest period of time. Lithium can also block the release of thyroid hormones, but we don't usually use that. It's seldomly used, and why that? We're scared. We're scared of the toxicity. Calcium channel blockers. Calcium channel blockers will be welcome for real control if we're dealing with an asthmatic patient. But remember, there's likelihood of congestive cardiac failure. We cannot use calcium channel blockers in heart failure. Beta blockers will be welcome, but not in asthmatic attack. So, Propranolol can actually inhibit type 1 dehydrogenase, which can lead to a reduction in T3 level. So, Propranolol will be serving two purposes here. One, handling adrenergic symptoms, and at the same time, helping to reduce the level of T3. But we can't use Propranolol in the face of asthmatic attack. Otherwise, we can use beta-1 selective or calcium channel blocker, but we can't use calcium channel blocker in the face of heart failure. So when you go over this entire presentation again, you will see that I've taken time to handle different scenarios with appropriate medications. And with that, I've come to the end of part 6 of 7 when it comes to hyperthyroidism. The next will be hyperthyroidism differential diagnosis. And that will form part 7 of 7 and the end of the entire series. Thanks for listening to my presentation. Please kindly remember to subscribe and share. I appreciate it.